Thank you very much, Mr. Secretary. Let me start. As I mentioned, you have a new announcement of a new initiative to expedite claims that have been waiting for over a year. And that's encouraging, and I'm glad to see that the Department's taking action, but I do have some questions about how it is going to be implemented. And I wanted to ask you, if the VA determines the veteran's final rating is lower than the provisional rating, will the Department seek to recover money that's already been paid to that veteran?
Madam Chairman, that's a question. What I would say is that historically, when we've established a standard for a veteran, we've usually stayed with that. And let me call on Secretary Hickey here, but my intent is that the provisional rating that's provided will be on those issues for which we have clarity and documentation, and we can render a decision. For issues where documentation isn't provided, those are the issues that will remain open up to a year for veterans to locate, or with our help even, documentation that would allow us to make a decision there. Secretary Hickey.
Chairman Murray, thank you for the question and for your interest in this initiative, which we think is really important to ensure that we're taking care of those veterans who have waited the longest while we completed the more than 260,000 Agent Orange NEMR claims to take care of our Vietnam veterans over the last 2.5 years. We are using the provisions that allow us to make good decisions, so we will continue under this provisional criteria to use service treatment records, to use private medical records, to use the information available to on our veterans in terms of their nature and character of their service. So all the similar evidence that we have used in previous decisions, we will use again to ensure that we don't make any of those kinds of decisions. I don't expect to see any of those decisions where we overcompensate for a claim. The other thing that we will do is we will keep, and the reason for the provisional decision, we put a really huge safety net under every one of our veterans. We're going to keep the record for a whole year there, the ability for our veterans to come back with additional evidence. And we will keep asking if we don't.
So the additional year, it will only be to provide information to have an additional claim, not to lower the claim.
The reason for the year is to allow additional evidence to increase the rating if necessary. So I think in that it advantages our veterans for that additional year. And then they still have, after that, the same appeal processes that they've had in the past. So we don't anticipate having conditions where we overpay a veteran under this initiative.
Mr. Secretary, are you going to need additional support from the Defense Department in order to meet the timelines you proposed?
For these particular claims?
Correct.
We're dealing with claims in our inventory right now, and so we are, I think we have as much control as we need. Of course, we work closely with the Defense Department on an ongoing basis because the sharing of data is something that goes on daily.
Okay. There's a number of other services that are contingent on a disability rating: benefits from health care, home loans, designation as a disabled veteran-owned small business. They all rely on the rating that you're talking about. How will this provisional rating affect those other benefits?
Secretary Hickey.
So, Chairman, thanks for the question. I will tell you that in the same way that we provide those additional benefits today associated with a claims decision, we will continue that avenue. I will say, though, that any veteran who's returning home today does not require a decision from us to seek the 5 years' worth of medical care that this Congress made provision for. They can still get that by just showing up to one of the VA medical hospitals or clinics and get that medical care for free without a decision, even today, associated with this a new initiative. It doesn't have an impact there. They still can get health care.
Okay. Under this initiative, as you just described, there's the provisional rating that will be given to them, and then they can make continued claims. So are we looking at increasing the workload by requiring 2 ratings decisions instead of 1?
Chairman, we're not. We are actually trying to benefit the veteran who has been waiting the longest in this case. We want to get a decision to them. If that veteran returns after the fact saying, I have additional information, we will expedite that claim to the front of the line. We'll re-rate it based on that additional information, and we'll get them a final decision.
Okay. There's a number of efforts going on, programs like benefits delivery at discharge and the fully developed claims process. Both have been accessible. They need to be maintained. A successful integrated disability evaluation system, the IDES, is critically important to our injured service members. There's a lot of work that still needs to be done from both DOD and VA on that, and we can't lose sight of the making improvements to fundamental issues in the claims processing that we still have. So are you going to be able to implement this new initiative and still support all those other efforts?
Chairman Murray, that is our intent. And as you implied earlier, this requires a level of continuous synchronization between DOD and VA. As you know, BDD, benefits delivery at discharge, quick start, IDES, integrated disability. These are DOD programs in which VA has provided our capability to support on medical exams. And so there is a good collaboration there. We do this best when we have some indication of what the flow is, and then we match up. About the only times we've run into difficulty here is when the flow exceeded what we thought it was going to be, and then there's a period in which we have to generate additional capability. But these are things we work on a daily basis.
Under the Mental Health Access Act that we passed, we required VA to develop new tools to determine exactly whether our VA facilities were meeting that 14-day standard that your answer to Senator Kane was on. We had found previously that that was not being met. I assume those new tools are in place now. Can you tell us now what the current wait times are according to this new tools that have been put in place and the staffing, any staffing shortfalls that you have?
Dr. Petzel.
Thank you, Mr. Secretary. Madam Chairman, we've done a number of things since we last talked about this in the Senate Veterans Affairs Committee. I want to just go through, before I talk about the wait times, a few of the other things that have been done. First of all, we have redone the way we measure wait times. We now use two different measures depending on whether you're a new patient into the system or whether you are an existing patient that's going for either further treatment or another kind of treatment. For new patients, it's the create date. So when you call or you walk in and say, I want to be seen or are judged to need to be seen for mental health, that's the starting time. Right. And the appointment time then is measured from that create date. Okay,
so knowing that, what are our current wait times? And my time is short, so I want to, if you can just answer the question.
About 50% of our patients are being seen in less than 14 days, and about 50% are being seen in more than 14 days right now. That's from November. We do not have data since we have gotten this going in the entire system. The average wait time for an appointment for a new patient that isn't walking in for an emergency is 15 days. So we're getting close. But we are not there, and I would openly admit that we've got work. And
if you could answer me in writing on the staffing levels, because that is a critical part of this, and it's certainly important to all of us. But I just wanted to quickly ask a couple other questions, and one of this is on the integrated healthcare record. It's been referred to back and forth here between the Department of Defense and the VA. We knew from the Walter Reed scandal time, that this was a critical effort. A lot of money has been put into this to have a coordinated record system. We considered the department's joint development of a single integrated electronic health care record as really a cornerstone of that whole solution, but the departments have now abandoned the development of a single record in favor of just interoperability between the two systems. We have a March 28th memorandum from the DOD Operational Test and Evaluation Director that criticizes DOD's approach to the IEHR development as being, quote, manifestly inconsistent with the President's open standards agenda for electronic healthcare records, and notes that this resistance appears to be based on an incorrect assumption that using open standards will take too much time. I disagree. I support the White House's approach to implementing open standards. Open source development brings together government, industry, academia, and drives innovation, and is the right way forward. Are you concerned that DoD's apparent preference for commercial software will make achieving true interoperability even more difficult?
Madam Chairman, let me just say, like you, I am committed to what we have been asked to produce here, and I would say that over my 4 years of working with Secretaries Gates and Panetta, and now Secretary Hagel, that both secretaries are committed to a single, joint, common, integrated electronic health record, open in architecture and non-proprietary in design, which is what the President asked us to go to work on. For Secretary Hagel, who arrived and was not familiar with the previous history on IEHR, he asked for time to get into it, understand where the program was. And so I await the next opportunity for the two of us to sit down here and ensure that the program is on track as we have committed to.
I hope that is going on forward, and I will certainly push DoD to do the same. There is a December 6, 2012 memo from the U.S. Chief Information Officer and U.S. Chief Technology Officer that requires VA and DoD to submit a number of documents regarding the status of the IHR program, and I would ask that you provide us with a complete set of those documents as well.
All right.
And finally, just really quickly on Washington State, I appreciate the VA hospital campus construction being part of the budget. As you know, that's ongoing. But we still have some clinics that are really now behind schedule. Bremerton is behind because the Navy decided not to pursue a joint clinic, and the budget request doesn't reflect that change. And there has to be some progress on opening the new clinic in the North Olympics Peninsula and addressing some of the staffing concerns. So I would just ask you if you could let me know back, you don't have to do it at this moment, where we are. We've got to expedite those clinics, and they remain a top priority of ours.
We will do that, Madam Chairman.
Thank you very much.